Hi everyone, welcome. We're so glad that you can join us today for our webinar, Stopping the Spread of Hepatitis C, Options to Incorporate Treatment in Your Practice. I'm Amber Jones and I'll be your host for today's session. We're excited to bring you practical evidence-based strategies to help you identify and treat hepatitis C in your patient population, regardless of, regardless of the care setting. We'll begin with Morgan Cole, an APRN with Solutions Health, who will walk us through the clinical background, testing requirements, and treatment considerations for patients with substance use and Hep C. Next, we'll hear from Kim Caudill, a clinical pharmacist at St. Matthew's Pharmacy, who will share insights on medication access and patient support. And then we'll wrap up with a Q&A session, so feel free to drop your questions into the Q&A at any time, and we'll go ahead and get started. Morgan, over to you.
Hello and good afternoon, everyone. If you are with us today, you recognize the role that substance use plays in the everyday life of almost 1/4 of Americans age 12 and older. What I'd like to discuss today is how chronic Hep C infection can play a huge role in the overall health of these patients. I'm really hoping to show you the potential impact that having access to treatment can affect not only our patients, but those around them as well. You can go ahead and switch, Amber. So when we talk about who is eligible for hepatitis C treatment, the AASLD recommends that all people with chronic Hep C get treated. Now, the one exception to this would be people with a very short life expectancy, one where treating the hepatitis C is not going to help. Other than that, the goal truly is to treat. There was previously a sobriety requirement, and there's really been an about face on that regard in the past couple of years. Some payers may still require 6 months of sobriety, but this is not something that I have personally run into at this time. When it comes to identifying hepatitis C infection, there's multiple ways that we could go about this. Maybe your patient had an abnormal liver labs on their CMP and we're trying to identify why that could be. Maybe they admit to IV drug use either currently or previously, and we found it just on a regular screening. Maybe they had a positive antibody at their community screening event. No matter what we want to make sure of is that we have the information we need to set patients up for success. Streamlining the diagnosing and linkage to treatment process is key to getting patients treated in a timely manner. The more steps in the process that there is, the less likely that these patients are to follow up. So if we can get all information needed at one time, perfection. There's also now an FDA-approved CLIA wave test for Hep C RNA that can decrease the time to diagnosis to under 1 hour. What you see on the left of this slide are testing requirements that your payers are going to absolutely require to treat hepatitis C. So we said hepatitis C viral load. I practice in Kentucky and Louisville, and the state of Kentucky has actually changed their rules around the hepatitis C viral load. You can actually just use a positive Hep C RNA now to treat. You don't have to have that precise number. You want to check for the hepatitis B surface antigen, and that is because these direct acting antivirals or DAAs can reactivate previous hepatitis B. So we want to make sure that these patients are Hep B negative. A comprehensive metabolic panel. So we have our liver function, our AST, our ALT, a CBC, so we can check for hemoglobin, hematocrit. We can check most importantly for platelets as well. And then we want to know our HIV status of our patients. If they're positive, then we need to treat HIV along with hepatitis C. If they're negative, that's an opportunity to discuss PrEP along with treating their hepatitis C. On the right, you will see 3 other tests that some payers may require. So the hepatitis C genotype, a FibroSure, a FibroScan, or a PTINR. And again, these are payer dependent, and the very few times that I have run into this when wanting to treat patients, St. Matthew's has gone above and beyond sending detailed information to the payers about updated guidelines, why these steps aren't necessarily needed, and has really gotten the patient what they needed, treatment, without all the additional steps that were initially requested. So when it comes to treating persons with opioid use, one of the big things that we want to note is that no matter what opioid they're using or how they are using it, this does not hasten their progression to liver disease or cirrhosis. What actually causes most transmissions within this population, we know, is equipment sharing. When it comes to transmission rates, research shows that once someone acquires hepatitis C, they will infect 20 other individuals within the first 3 years of being diagnosed. So if we think about this even just mathematically and we treat and cure one person, we have the potential to save 20 other infections, and so on and so on. And then, of course, combining treatment with harm reduction supplies, education, and medications for opioid use disorder can further decrease transmission and increase our healthy outcomes. One of the big things that I get asked as a provider who is taking care of people who use substances, people who are living on the street, is about the common misconception that these people don't desire access to healthcare or that they don't really care about their own health. Running the clinic that I run here in Louisville, I can say that that is 100% not true. Not only when it comes just to accessing general health care, it's the same when it comes to accessing HIV prevention with PrEP, treatment for STIs, and treatment for hepatitis C. Besides my personal experience, which is anecdotal at best, there is actual research that shows that persons with recent or active IV drug use who are being treated with the DAAs and medication for opioid use disorder, they have completion rates and sustained viral response or SVR rates comparable to other study participants. So SVR, or sustained viral response, is actually how we check for a cure in hepatitis C. And what I really want to highlight with this slide is that with the newer treatment options that are available, SVR is possible. The options that are out there today are pan-genotypic, meaning that no matter the genotype of Hep C that the patient has, the medication can be used. And that's what this top left graph is showing us, is that, it's divided up by the genotype, but no matter what, treatment and clearance of Hep C is possible. Treating despite the presence or absence of cirrhosis, despite the level of Hep C RNA that is found, despite having a positive or negative urine tox screen, and whether or not they have opioid substitute therapy at the same time, the takeaway from all of these slides is the same. We have to treat no matter what. Reinfection is definitely something that I talk to my patients about, and I spend a lot of time kind of drilling this into them because, yes, it is 100% possible to become reinfected. Can they be treated again? Absolutely, they can be treated again, but it's actually easier just to avoid the things that may lead to reinfection. So we talk about sharing injecting supplies, even down to the cotton swabs. We don't want to even be sharing those. I talk about safe sex 100% of the time, using condoms, using lube, especially in my population of men who have sex with men. We know that anal receptive sex is high risk for Hep C acquisition. So I really kind of want to drive that point home with them as well. When it comes to treating people with stimulant use, there's not a lot of research on people who just used stimulants. Now, injecting stimulants carries the same risk as injecting opioids, and snorting stimulants may also carry some risk because if we think about how vascular our nose is, obviously that's going to be a pathway for infection. Again, there is no sobriety requirement, and when it comes to outcomes, those with stimulant use are similar to those with opioid use. This was actually looked at in the HERO study, which did urine tox screens and showed that 32% of participants were not only positive for opioids, but they were also positive for meth, and 42% were positive for opioids and cocaine. And despite that, the sustained viral response, or SVR, remained between 90 and 94%. So our patients with alcohol use, this is the one population where the substance that they are using can actually precipitate hepatic fibrosis, which can lead to cirrhosis and can lead to liver cancer. What does heavy alcohol use look like though? Well, in men, it's 60 grams of alcohol in a day. And in women, it's 40 grams of alcohol in a day. But I don't know what a gram of alcohol is, so you might not either. There's 12 grams of alcohol in 1.5 ounces of whiskey, or there's 12 grams of alcohol in a 12-ounce beer. So one of the biggest takeaways with this population is even if we treat their hepatitis C and they continue to drink heavily, they can continue to damage their liver. And that's really what this graph represents, is that when you combine heavy alcohol use with Hep C, your risk of cirrhosis and thereby hepatic cellular carcinoma increases more and more as time goes on. But again, SVR rates are the same. Despite the genotype, the presence or absence of cirrhosis, the amount of alcohol consumed, the SVR rates are similar within these populations. So what does all of this mean for those of us on this call? We could all likely be doing better when it comes to doing more to identifying and treating hepatitis C. So that's what I want to challenge you with today, or that's what I want you to kind of take away and think about today is what are your current protocols around hepatitis C? How can we make them better? How can they be more streamlined and patient friendly? How can we make it easier for those that need treatment to access it? If you're treating in your clinic already, you're treating yourself, awesome. That's amazing. See if you can get one more patient a week treated. If you're not treating yourself, start. I was an urgent care nurse practitioner a year and a half ago. And with the resources online, the resources that are available to me, not only through St. Matthew's Pharmacy, but through the drug reps that are out there providing education, you can absolutely start treating hepatitis C yourself. So with that, I am going to send it over to the amazing pharmacist at St. Matthew's, Kim.
Thanks, Morgan. Good afternoon. I'm Kim Caudill, the Senior Clinical Pharmacist at St. Matthew's Specialty Pharmacy. And I thought when they gave me the title senior that it had to do with knowledge, but as time goes on, I've figured out that it mainly has to do with the amount of time I've been roaming around the halls here at St. Matthew's. So I have on the call with me today the clinical services manager, Melinda Kromsky, who will help with the Q&A session at the end of our call. So we're going to talk today about the direct-acting antivirals, and a lot of this is just going to be a reiteration of some things that Morgan went over. The direct-acting antivirals are the cornerstone of modern hepatitis C treatment. There were, back about 10 years ago, a lot of the medications that we used to treat hepatitis C were difficult for patients to take. You had to be on them for a really long time. They made you feel really bad. The new direct-acting antivirals are much better in a way of side effect profile, and they the new direct-acting antivirals, the comparison of those, Mavorite and Epclusa, they are the most common ones that we use these days. And the old ones like Zepatier and Harvoni have fallen out of favor due to the fact that they were not pangenotypic. They did not treat patients very well, so they weren't as effective. The new medications are nearly 100% effective, I think upwards of 95%. So let's just talk about the mechanism of action of the direct-acting antivirals. They work by preventing viral replication. So we use a combination of two drugs for those, and they're listed here on the slide. By doing that, we make the virus less likely to develop resistance, increase effectiveness, and allows us to shorten the duration of therapy. There are several side effects. That's the important thing to note, or not, I'm sorry, not several side effects, several drug interactions. That's the important thing to note here. There's really good charts in the patient package insert that shows those. So you'll want to definitely take a look in there to make sure that you're checking to see if patients have any other medications that would need adjustment with Mavorite or Epclusa. For example, anything that goes through the CYP enzymes in the liver are definitely going to need to have an interaction check just to make sure that they don't interact with the medication. That's largely going to guide along with insurance as to what medication you're going to select for a particular patient. For example, if a patient is on amiodarone, there is a significant clinical interaction with that if they're taking Epclusa. And patients who have predisposed heart conditions or that are on beta blockers, it causes a really significant bradycardia. So those are things that you're going to want to take into consideration when you are choosing which medication to prescribe for your patients. Again, just to reiterate, there's also boxed warnings on both Mavorite and Epclusa for hepatitis B reactivation. Morgan went over that extensively, so it's just something good to remember. And let's see. So the next slide we have is the hepatitis C treatment cycle. This is something that we've developed to help you know kind of how we are able to assist in the treatment of hepatitis C. So once you've ordered the labs, and I won't bother going through those, although we do have a list that we can send out, but Morgan went through those extensively. And so once you have identified a patient that's Hep C positive, then you decide whether you're going to treat yourself or whether you're going to refer out for someone else to treat. And so once you make that decision, if you're going to treat yourself, then you would send us the prescription, and then we will do a benefits investigation to determine the insurance coverage for that patient. At St. Matthew's, that includes any additional things that we can do to help patients if costs are high. We can get foundational support to be able to cover high copays. So we would go ahead and do all of that to determine what the patient's out-of-pocket cost would be, if any. And then once that's done, also, we definitely are able to help with prior authorization support. So hepatitis C is notoriously known for being difficult to treat simply because the prior authorizations can be quite extensive. Luckily, we're able to help with that. And Melinda Kromsky, who's also on this call, is a great resource for that. She's the one that submits or does all of our hepatitis, not submits, but assists with our hepatitis prior authorizations. So she's very knowledgeable on what the insurances require in way of that. So she's a great resource to have for assistance on prior authorizations. So once that's done, we then can get the medication shipped out to the patient. There's two options for where we can ship. We sometimes ship directly to a patient's home, but sometimes if they're coming into your office for substance use disorder treatment, we can also ship to your office if it's easier for you to manage getting the patients in to actually pick up their medication. Once we decide whether we're going to ship it to the patient or to the provider's office, we then reach out to the patient to do some education on the medication and care plans. It's just part of being a specialty pharmacy. Those are things that we do month in and month out, make sure to follow up with the patients, and we check with them to make sure that they're completing therapy. So we can also assist by counseling them to make sure that they're keeping their appointments with your office as well. So I think that's pretty much everything that we had. If there's any questions, I'll give it back over to Amber, the moderator.
Yeah, thank you. That wraps up our presentation today. Thank you everyone for your attention and for your engagement. We'd now like to open it up to questions. So if you have any and you haven't already, feel free to drop those questions into the Q&A, and we'll do our best to answer as many as we can today. So I'll take a look at what's come in so far. First one that I have is probably Morgan for you. Can you tell me a little bit more about the machine that's used for rapid diagnosis?
Yeah, so it is called a Cepheid machine, and while you can run multiple varying tests on it, we use it in our office for hepatitis C RNA. So in the population that I treat, almost all of them have a positive Hep C antibody. And so previously, we would either have to draw labs ourselves or have them go to the lab to get labs obtained to see, are you actually acutely infected with hepatitis C? Do we need to treat you? Well, since getting this machine, it takes anywhere from 45 to 55 minutes to run the test, but it actually tells us, yes, hepatitis C RNA is present or not present, thereby leading our treatment or what we need to do at that same time, same day. And like I said earlier, the state of Kentucky has now changed for state Medicare, Medicaid, they have changed that we can treat based off of just that Hep C RNA being present. We don't have to draw a quantitative Hep C RNA, which again, one extra tube that I don't have to draw on a patient that's a difficult stick, that was huge for us. So we love our little machine. It's portable. We've just got a second one as well. So we take it everywhere with us.
Thank you, Morgan. Next question that I have here is, what does prior authorization assistance look like from St. Matthew's Pharmacy?
Do you want me to answer that from my
I'll-
end? Because these girls right here are amazing, and I just have to go in to cover my meds and click a button. As a provider who's never had to work the prior auth, process before, that was one of the scariest things for me coming into this space and treating the patients I'm treating. But Melinda, Kim, everybody here has made that extremely easy for me. So that's what I can say from a provider perspective.
Thanks, Morgan. As long as it doesn't involve enlarging your slides during your presentation, we're good. Melinda, you want to go ahead and give our perspective from your side on some tips that might make things easier?
Yes. Can you hear me okay?
Yes.
Yes.
Okay, good. It was telling me my mic was stuck in unmute, so wanted to make sure.
Good. Good. It's not just me.
For us, we will help to collect all of the information that's clinically needed for the prior authorization. So we'll reach out if there's anything needed that was not already sent over. That way we can help answer all of the clinical questions. With hepatitis C, it is best to submit the PAs when all of their requirements are met prior to submission, because if you move into the appeal status, it can take anywhere from up to 30 to 90 days. So we're going to make sure that we have everything we need up front before you all get those submitted. But once we have everything we need, we're going to go in and help answer all of the clinical questions. And then we're going to just send it over for your review and submission. Cover My Meds does require the providers to be the submit to plan or submitters to plan, just to be most compliant with Medicare and Medicaid laws and rules. That is why we can't submit to plan, where we actually don't even have the capability. So we'll go ahead and answer everything that we can and then shoot it over to you all for review and submission.
Great. Thanks, Melinda. Next question is back to you, Morgan. It's about the rapid testing machine. Can you just spell the name of the rapid machine?
CEPHEID.
Thank you. Okay. Next question that I have here is, what strategies work well or work the best for integrating hepatitis C testing into routine care?
So I think if you're just following standards of care or following like the AASLD guidelines, the USPSTF guidelines, everybody over the age of 18 gets screened at least once in their lifetime. But if you have a population that we know are at higher risks, screening them more often is definitely going to be the most appropriate thing to do. Because I run a sexual health clinic, these are conversations I'm having every day with patients. And so it's very easy to incorporate this testing into our everyday visits. But the patients themselves know they're at an increased risk for hepatitis C. And so a lot of them even come to you and say, I know I have it, I know I need treatment. But if you're following guidelines, you're going to be having this discussion anyway. If you're treating substance users, then you're going to be having this discussion more often than not. And it's just a part of what we should be doing regardless.
Perfect. I have another question that goes back to the rapid testing machine that I'm not going to try to pronounce myself. Is there funding to obtain those machines to have them available within clinics?
So we got our initial machine through a grant we are a focus partner. So we do a lot of HIV and Hep C testing and identification within our clinic. And we got our first machine through the grant. We then reached out to the state of Kentucky to ask for additional funding. I know it is available to purchase. It is also available to lease or rent, our other options as well. But I know the purchase price, if you're buying it outright, is around $30,000.
Thank you. Next question is, are hepatitis medication prescriptions delivered month to month? Does the pharmacy automatically send out the refills, or does the staff/patient have to call the pharmacy and give permission to mail out the next refill? So
I'll take
Melinda.
this.
Yeah.
Yeah, I'll take this one. We will help manage refills proactively due to Medicaid and Medicare policies. We cannot autofill and auto ship any medication out without communication with the patient. And the reason we use our referral forms is because it's going to sign over that liability to the provider. So we are flexible in that we can coordinate deliveries with the office. And for patients that don't have phones and you can't reach them, we do coordinate those refills to ensure that patients are still on therapy before sending it to the office. But we're going to proactively do that. We don't wait for patients to call us, we call them. We find that really just helps with adherence, and we're just going to keep them on track. These patients need that little bit of extra help. So we do that across the board for all of our medications and specialties. So that is really helpful for checking in to make sure they're taking it correctly, having any side effects that need to be addressed right away, and keeping them adherent to their treatment.
Great. Thanks, Melinda. It looks like we've got time for one more question and then we'll wrap up today. So Morgan, probably one for you again. How do you handle cases where patients have co-occurring conditions like HIV or hepatitis B?
So if somebody has hepatitis B, I actually refer them to a liver specialist. That requires long-term management, long-term follow-up, and that's not something that I am comfortable or capable of managing within the confines of my office. If they are an HIV patient and they're a pretty straightforward HIV patient, their labs are stable, I can manage both of those things concurrently within my space. But if their numbers aren't doing what I need them to do when it comes to HIV, if their CD4 counts aren't where I need them to be, if they're not responding to therapy, then again, that's somebody that I would refer out to infectious disease to have them evaluated and managed. But if majority of HIV patients I have are pretty straightforward, along with hepatitis C, I do have a couple patients right now that have both, and we're managing them both in monitoring. So straightforward, you could easily manage within your space.
That's usually what we see most providers that work with us do, Morgan. They definitely, if anything is too complicated. In fact, the information that I've got on the slides was basically for treatment naive patients, patients that have been treated previously with something, or patients that have more complex coexisting conditions. We typically see most providers refer them out to specialists, either gastroenterologists or hepatologists.
Perfect. Great. Well, it looks like we're at the end of our time today. Thank you everyone for your engagement and for your great questions. If we did not get to your question, don't worry, we'll follow up after the session with answers and additional resources. We appreciate everyone's time and commitment to improving hepatitis care in your communities. Thank you again to our presenters, Morgan, Kim, and Melinda, and we hope to see you all at a future session. Thank you.